Good morning. I'm Dr. Bishal Kewali. I'm an assistant professor at Queen's University in Canada. Previously, I was in Brigham and Women's Hospital in Boston. And I say that both the speakers today have been affiliated with Harvard Medical School before, so I feel like home. And of course, our session co-chair, Dr. Julie Gralo too. And it's my huge honor and pleasure to be here today. I'm co-chairing this session with one of my most favorite inspirational oncologists who has also been working in Nepal. And actually, Dr. Tim Erickson, our first speaker for today, who will be on webcast shortly, has also worked a lot in Nepal, as well as in countries like India, Ukraine, and Syria. He's an emergency medicine physician at the Brigham and Women's Hospital and a faculty member at Harvard Medical School. So please join me in welcoming Dr. Tim Erickson in sharing his experience about addressing cancer health among victims of conflict and disaster.
Again, I'll do my best to address this briefly. I appreciate your patience with the technical difficulties. Wanted to briefly discuss about mechanisms to address cancer health among victims of conflict and disaster. As you know, over the past decade or so, the number of global migrations and refugees has increased dramatically due to war, violence, persecutions in their homeland. And this migration, of course, affects not only physical, but mental and social health. And important to this symposium, cancer health. And if we look at world migration patterns, since we've been recording them in the 1500s, we can see that not since World War II have we seen such a large amount of migration patterns of refugees, not only across borders internationally, but interstate or internal migration. And with migration, not only do we see morbidity, but certainly the mortality or case fatality goes up exponentially. And this has been most pronounced in the Mediterranean region as the North Africans have been going in large record numbers into Europe. And because of the political instability in these countries, there really have been more of a departure than a destination. And migration flows into the Euro-Mediterranean countries, of course, have occurred through illegal or very dangerous routes. And if you look at the patterns today, not only do we see this in the Mediterranean regions into Europe, but certainly in South and Central America, going into North America, as we've seen in the controversial areas of our south border of the United States. Global racial and ethnic disparities exist in treatments and outcomes, as we well know, and it's been highlighted at this very important symposium in Seattle, particularly for cancer patients. And there has been little published data on these issues related to cultural and linguistics and diversity of backgrounds. And that's, again, why I applaud Binay and his team for holding a conference like the current one in Seattle. Many languages don't even have a word for cancer. And that may be due to cultural regions, religious regions, but also because many of these low to middle income countries don't have the life expectancy to diagnose or treat some of the later stages of cancer. And there's a substantial variation in health inequities according to income, education, gender, and migrant status. While higher socioeconomic status position is associated with much better related health. If you look globally, cancer is now the second leading cause of death after cardiovascular disease. Long-term cancer survival has improved in the Western world because of early detection, effective combined treatment modalities such as immunotherapy, drug-targeted therapy, but these are not available to low to middle income countries. And because of that, there's an alarming increase in the global burden of cancer. Now, the molecular basis of racial disparity in cancer ranges from genetic polymorphisms to cancer driver gene mutations to obesity, and as you well know, chronic inflammation and immune responses. What's very disturbing is the number of new cases of childhood cancer. This continues to rise. There's a widening gap in outcome across countries, and this is despite the availability of highly effective cures for some childhood cancers, particularly leukemias, such as ALL and AML. And worldwide, we're seeing older adults accounting for over half of cancer cases. And this is going to go up disproportionately. And of course, these older individuals have less access to cancer care and the financial means to have the latest treatments. If we look at Malaysia, for example, the second most common cause of cancer in both male and females in Malaysia is colon cancer. And as you well know, that is the fourth or fifth leading cause globally. So we're going to see much more in terms of this in their aging populations. Migrants, in particular, have a higher mortality rate from infectious diseases, diabetes-related causes, respiratory diseases, and because of that, we see more lung cancer, particularly in female migrants. And in indigenous women, particularly those in populations like Aborigines, we see that they have not only a genetic predisposition to cancer such as cervical cancer, but certainly environmentally there are some concerns. And if you look at cervical cancer in particular, East Africa, Central Africa, Southeast Asia have higher rates of cervical cancer. And this is despite the fact we have remedies and preventions available against HPV and testing and even cost-effective means of detecting cervical cancer such as acetic acid and treatment with cryotherapy. If you look at African immigrants and refugees, over the most recent years, nearly half are from the Somali patient population, and they do have a higher rate of cervical cancer, and they seem to have less complications from colorectal cancer, but have less apt screening, such as mammography and pap smears. And we know that mammography can really help in detecting breast cancer, and yet these refugees and immigrant women have no access to adequate mammography. Filipino women, for example, have double the rate of breast cancer as Asian and other African women, and we need screening in this particular country, which has had a lot of recent political unrest. And there have been successful programs. If you look at even in the Bosnia conflict, there were cultural, religious, and very patient-targeted screening programs which were sensitive to these differences in culture and religion, and they had quite a good success in early detection of breast cancer. So it can be done even in low, middle-income countries, particularly those in conflict. Barriers to care for refugee women include pain, of course, fear, modesty. The women in conflict tend to really put their efforts into protecting their own children. They put their own interests and health aside, and therefore outreach efforts to them are even more complicated by the fact they are selfless and care for their family and children first and themselves second. Because of this, there's disparities in cancer screening, treatment, and survivability, and we're starting to look at mortality to incidence ratios to evaluate such disparities. Latin America is very interesting because there's tremendous gaps and disparities between individual countries. For example, if I have cancer in Costa Rica, or even Panama, I'm going to do much better than if I have those similar cancers in Honduras or Nicaragua. And as you well know, it's not just treating these cancers with chemotherapy and immunotherapy, and CAR T cell, cutting edge frontiers in cancer care, but oftentimes we need surgical intervention. And there is a lack of those surgeons who are specialized in surgical oncology, and there's a very, very great need for good surgical oncologists. And if you look at the immigrants that come through and go to different countries that are quite affluent, like Denmark, Germany, Norway, we find that even in these countries where the healthcare system is quite good, the screening programs and the outreach to refugees and migrants, even with good intention, is not as good and actually suboptimal. Of interest, those that come in as a migrant or refugee as a first generation, they tend to do worse than their children. The children get acclimated and get into the culture and are better at health access. Men, on the other hand, tend to come into new countries as migrants. They were once the breadwinners of these families, and now they're in a country where they are second, third, fourth class citizens. They've lost their pride. There's a lot of depression, and they're not apt to go through preventative health or screening programs. There have been some successes. Canada has done a good job in treating migrant and refugees. Norway is making better strides now that they see there is a gap even in their own country. And Switzerland, which takes great pride in universal health care, has acknowledged the fact that they need to do much better with the migrants and refugees therein. Now, refugees and migrants are different categories. They tend to get lumped together. And those that cross international borders are what we stereotypically think of a migrant. But there's also those that go internally. They don't want to leave their country, but they'll leave one region of the country to another. It's called internal migration. And there's a large migratory pattern now going from the rural to the urban areas, the mega cities, because of a lack of employment and resources in the rural sectors. Climate change has had a huge impact on health disparities, particularly as it relates to cancer care. Never have we seen such a shift in populations due to climate change related water scarcity, food acquisition, farmable land, and because of that, massive populations are moving into areas of conflict and around areas of conflict due to climate change. And those that need to go for water, the scarcity it is, of course, you know, is generally the women and the children. And their whole day is spent finding clean sources of water. So these are not patients that are going to seek out primary care, preventive medicine, screening, vaccinations, because they're so concerned about their family, their children, and a lack of a water supply. We've looked at migrants from the Iraq War since 2003. Over 4 million Iraqis have been displaced. And little is known about their cancer care or preventative screenings. Syria is our most recent example. And Syria is very unique in that before the conflict in the Syrian war, this was a highly regarded healthcare system. In fact, Damascus hosted many of the board certification for those health providers in the Middle East. They're very proud people. They want to rebuild Syria and redevelop a premier healthcare system. They don't want to leave the country. So it makes this a very, very unique situation. And yet the Syrian crisis has created an unprecedented strain on healthcare services and symptoms all over the world. And for the first time, we're seeing not only an exodus of healthcare providers who are highly well trained, but a deliberate attack on healthcare systems. Also, it's very difficult to deliver medical supplies to these areas of conflict. They have to go through dangerous routes across borders that are right along Syria, such as Lebanon, Jordan, and Turkey. And I don't have to remind you that those that have given their lives for the care of patients and cancer patients have been deliberately targeted and not looked at as neutral. And yet these physicians, these nurses, these pharmacists, these paramedics have taken care of patients on both sides of the conflict, and yet they've given up their lives for the better of those around them. And then if that isn't bad enough, we see the use of chemical weaponry against children and innocent victims to better a cause. And it's not a better cause. We've seen this in Darfur and South Sudan and increasing numbers of human rights violations. The recent war in Libya is yet another one that's led to mass migration and strains. Most recently, the Yemenis war has ignited health disparities, and cancer crisis is predicted to be one of the most dramatic and underserved areas of the world. I think we need to start focusing efforts on Yemen, and in the next 2 to 5 years, I think this is going to become a much bigger conflict and a world conflict. It's important to document the effects of war and conflict on public health. We need to get policymakers behind this. We need to protect human rights, document violations of humanitarian law. And with children, many of them are forced, they're kidnapped, they're orphaned, they become child soldiers. And so to follow them, to treat them in cancer prevention programs is very, very difficult. Just the access to these children are difficult. They grow up much too quickly just to survive. And as I mentioned, there are internal displacement conflicts. Colombia has been an ongoing conflict with a lot of internal displacement, as we've seen in Ukraine with the recent Russian-Ukrainian conflict. And with conflict comes not only cancer-related issues, cardiovascular-related issues, diabetes, but mental health. Existing evidence suggests that mental health disorders have a high prevalence rate in war refugees, particularly after resettlement, even more so than during the migration pattern itself. Mental illness in terms of anxiety, depression, low self-esteem, post-traumatic stress disorder are highly elevated amongst refugees, and we need to increase attention towards this, particularly if we're going to reach out to this patient population for cancer screening, prevention, and treatment. And you know better than I do that stress is a major contributing factor to cancer. It lowers your immunodefense mechanisms and makes you more predisposed to cancer. And those that are in other countries don't have universal health. They may not even have access to emergency care. And women who are more prone to breast cancer when they're under stress, again, are not going to seek out their own care. They're going to protect their children before themselves. One very important phenomenon that's been observed, particularly in our Latino migrants, is the ones that come into the U.S. to work and go back home across the border, say in Mexico, tend to have better health. It's called the salmon bias, like the salmon stream swimming upstream. This is opposed to the Ulysses syndrome, where refugees and asylum seekers, like we see in Europe, never have the ability to go back home. Migrants from non-Western countries are more prone to cancers that are related to infectious etiologies, such as the liver, cervical, and stomach cancer. In contrast, as we know, in the Western world, we have more cancers of lifestyle, colorectal, breast, and prostate. Those countries with lack of cancer care, there's promise with telemedicine type programs, DME to the physicians there, and those of you who are dealing with low to middle income countries and teaching cancer awareness, prevention, screening, and treatment, I applaud you. What we also need, of course, are clinical trials, the foundation of cancer care. good clinical trials, and yet if you look at those that are enrolled in these trials, they are not necessarily those in low-income countries. Certainly, it is difficult to enroll refugees, migrants in these studies, but it has to be done. Many of our countries that are in conflict experience brain drain, and many of these leaders in health never return, even though they want to. Their families are in danger, and then the country takes 20 to 25 years to recover their healthcare system. We like to do genetic testing and counseling for cancers, but the patients that need it don't have access to genetic counseling, nor do the children for their offspring. Cancer mortality has declined overall in years, as we know, but the disparities continues and cancers increase internationally. Breast and cervical cancers disproportionately affect African American, Hispanic, and American First Nation women. Colorectal cancer is now the second leading cause of death for Latinos. In his administration, President Barack Obama tried to launch the Cancer Moonshot, the All of Us research program, which was formerly the Precision Medicine Initiative Cohort Program, directly to try and impact cancer health disparities. We have yet to see whether this has been successful or not. But as we move forward in the setting of humanitarian crisis like war, cancer diagnosis amongst refugees is a major health burden. And it's not only on the refugee population, but the host nation. Now, if we can get medications, pain medications, chemotherapeutic agents through these nations, oftentimes in conflict, they're head off. And these medications and healthcare providers are kidnapped or it's sold on the black market. And the medications that need to get to those most in need are never delivered. Also, those that have cancer diagnosed in these settings tend to be more advanced, and therefore their prognosis is much poorer. And those physicians and healthcare workers that choose to treat those that are underserved also need to make sure they are neutral and treating both sides. Certainly in cancer care, end-of-life plans, palliative care, it's very important to know that these patients, too, need to be involved in this decision. And with conflict, there's suspicion, there's mistrust, and often healthcare providers are accused of not helping those in need because they are on the other side. We need to smash those barriers and take care of anyone, regardless of what side they're on, because most of them, of course, are innocent bystanders in conflict. Great disasters that we see with hurricanes, typhoons, cyclones. An example is Hurricane Katrina in the U.S. More disparities and less cancer outreach. We've seen this in the Haitian earthquake of 2010, the Nepal earthquake, where Vinay is doing a lot of extraordinary work, and his team that was challenged with cancer care, and certainly the West African Ebola epidemic. Everything was focused on Ebola, and appropriately so, but other types of disease, particularly cancer, was put the wayside and even ignored. We've seen cancer issues with natural and man-made disasters like Fukushima in Japan, Chernobyl in the Ukraine, where now those that tried to rescue Ukraine, the liquidators that covered the reactor with the sarcophagus, are now experiencing late-stage, late-life leukemias. And that's not to mention those that went through the tragedy of Hiroshima and Nagasaki. So in final, just to respect the time, refugees are human beings, migrants are human beings. They need to be treated as such. They need to be represented and cared for, particularly when cancer screening comes to fruition. When a country is engulfed in war or overrun by a dictator who begins killing its citizens or forced to flee, in such situations, the only compassionate response is really to take people in. With the ongoing mass migration we're seeing all over the world, and the vulnerable people that are paying high prices for smugglers to take them in, they go to places where no one wants them, and they leave in a rush to save their lives, their families, due to political and religious fear, death threats, forced labor. There's no ideal migration. They don't know what countries will take them in. There's no safe haven, but we need to be there for these asylum seekers. Refugees share a common experience of displacement from their country of origin, migration, resettlement in an unfamiliar country. Right now we have over 20 million people that have recently fled their home due to countries in war, violence, and persecution. Will continue to be challenged by language and cultural barriers, high rates of mental health disorders, higher prevalence of latent infections, and of course, new onset and exacerbations of chronic diseases, in particular cancer. Again, I'm sorry that we went through technical difficulties, and if you've been unable to see my slides, I did give those to have those, and I'll stop right there and allow you to continue your conference. I believe with all my heart that this initiative and the symposium that's currently in Seattle is the right step. It's not just our nation that's important, it's the nations around the globe that are needing attention, needing care, needing outreach. And it's not enough for us to say our system works there. We need to adapt to their culture, their beliefs, and meet them and prevent cancer before it hits, because so many times it's too late to really intervene, particularly in the current situation. So thank you for your time and listening, and I'm happy to entertain any questions or comments. Thank you.
Well, Dr. Tim Erickson is from Harvard School of Medicine, and he is an amazing global health leader. I have known him for many years, and he established UIC, Center for Global Health, right from the scratch. There was no Center for Global Health there. Right now, he is a core faculty member at Harvard Humanitarian Initiative, and he has been pursuing his humanitarian projects all over the world. And I can tell you this, having done global health for so many years, it is hard to imagine many people who are, who come close to his humanitarian thoughts and projects and what he has done and what he has achieved. Tim, thank you so much for all your support, all your help, and on top of that, we are really proud of him as board of director of the foundation. Tim, thank you. And we are going to move on to our next talk because of the delay, and we will send you questions through emails, and we are going to connect them to the individuals who have questions.
Thank you.
Our next topic is biosimilars in oncology, current state and future. And we have the great honor and pleasure of having Dr. Gary Lyman to present about biosimilars, who is also, who doesn't need any introduction, of course, you all know him, but who is also in the ASCO working group on biosimilars in oncology. He is the senior lead of healthcare quality and policy of the Hutchinson Institute for Cancer Outcomes Research and member of the Public Health Sciences and Clinical Research Divisions at the Fred Hutch. He is also a professor of medicine at University of Washington, and we are really honored to have him speak about biosimilars in oncology. This is a topic that is very close to all of us who are interested in lowering the cost of care, having access to patients in low and middle income countries to new molecules. So please welcome me in, please join me in welcoming Dr. Lyman. Thank you.
Thank you, Bashal and Julie, and good morning to all of you. Yesterday we had a debate about the U.S. healthcare system and the issue of rising healthcare costs and some of the challenges and perhaps some of the paths forward for dealing with the unsustainable rise in healthcare expenditures. Obviously, it's a multifaceted issue, as came out in that discussion. It's hospital costs, it's imaging technology costs, it's drug costs, and many factors go into this. But clearly, steep and rising costs. I'll show you my disclosures here as we head into this. But clearly, among these costs, as I alluded to, is the very steep rise in cancer drug costs. So I do want to emphasize in the beginning, solving the drug cost issue is not going to solve the U.S. healthcare crisis or even the cancer care cost crisis, but it is a component, and it is one of the drivers of rising healthcare costs. Drug costs have increased more rapidly than other aspects of cancer care expenditures, which of course have exceeded the overall healthcare expenditures in the U.S., and all this, of course, rising more rapidly than the U.S. gross domestic product. So, and you see here on the right some of the drugs here, and so one of the features of this, and those of you who are practicing oncologists are very much aware of this, it comes with a good news and a bad news. The good news is we have numerous and a whole pipeline of exciting new biologic therapies, which have frankly revolutionized oncology care and continue to do so, and will continue to do so for the years and probably decades ahead. It's targeted therapies, it's oncology drugs. This has been an extremely exciting time for those of us that have been in the field for many years and have gone through droughts as well as what seems to be a plethora of new agents. However, there's a dark side to all of this, and I think we're all aware of it, and that is the cost of these drugs, almost from the time they're approved and then continuing to increase as they're in the marketplace. The cost has become a major obstacle to access to care. It's imposed enormous burden on cancer patients and their families. It's led some patients to be denied therapy or not accept therapy because of their fear of what's going to happen to their families and the economic stability of their household. And even those that go through this, of course, they're left with this enormous financial burden. As we discussed yesterday, it's driven to higher bankruptcy rates among cancer patients and their families. And we've even shown in data that those patients with cancer who go through bankruptcy have a higher mortality rate than other comparable cancer patients. So it's an enormous issue. So this, as I said, is in part driven by the new biologic revolution in oncology. You can see here the rise in global biologic therapy sales, and it's continued to go up even over the last couple of years. And this is an access problem. It's become an access and a burden on the healthcare system and on the patients we care for. I think a very telling graphic that some of you have seen here that was in an article in Nature a couple of years ago is, and this has continued to be the case, that we now know that the median cost of drugs on a monthly basis of new drugs in oncology now is more than double the median family household income in the United States, which has remained relatively flat. And of course, this trend has continued, and I think it just highlights this disparity between drug costs and families' ability to sustain coverage and care. So one solution to this that's been put forward by the FDA, by the Center for Medicare Medicaid Services, the President's Cancer Panel this past year issuing a report to the White House, and even the White House in a document that they released, all saying one aspect of this that perhaps we can begin to get our hands around would be as the patents expire on these expensive drugs. Of course, they have patent protections for a decade, sometimes 2 decades. As those patents expire, can we bring competition to the marketplace by developing, they're not generics, as you know, but highly similar products, biologic products that can compete in the marketplace and through competition within our healthcare system drive down the cost of these drugs. So FDA has formally defined a biosimilar as a biologic product that's highly similar to a U.S. licensed reference product and has no clinically meaningful differences in safety, purity, or potency. So there are differences, of course, between generics, illustrated on the left-hand side of this chart with aspirin, and a biosimilar, illustrated here by a monoclonal antibody, which of course is a much larger molecule. It's a very complex molecule. It's produced in living systems as opposed to a chemical reaction in the laboratory. It's impossible to completely characterize the tertiary structure of these complex molecules that are produced in living systems. They're inherently unstable and sensitive to external conditions. And of course, they're proteins, and they are potentially immunogenic. So all these are some differences between what we become very familiar with in medicine, and that is generic products, which we know are developed for the same reason, that is to competitively reduce prices on medications. But they're far more complicated. So the FDA has established regulations, regulatory approval process for these products, again, as the patents expire on the original biologic product. The proposed biosimilar from a company, it has to be, again, highly similar. We can't say it's identical to the reference product, but it should not have meaningful differences in these, except perhaps in some clinically inactive elements. So no meaningful clinical differences between the biologic product and the reference product that has been in the market for some time. So the FDA has developed a stepwise process where the focus is not on the clinical trial data that we're so used to with drug approval, several large phase 3 clinical trials that have led to approval of these agents. But the focus is more on the molecular characterization, the analytic look at these agents. And frankly, over this time period, the last 10 to 20 years, the technology, the ability to characterize the molecular structure and function of these molecules has increased tremendously. So there's quite a bit of assurance that this analytic characterization of these molecules and comparing it to the reference biologic is very effective at pointing out any similarities or differences. And then if there's remaining uncertainty, of course, there's preclinical work in animals, particularly pharmacokinetic and pharmacodynamic work, and make sure the mechanism of action of the biosimilar is the same as the originator. There has to be some human data. It's often done in healthy volunteers because they're not immunosuppressed, and so they're more likely to reveal any problems in terms of immunogenicity or problems with the pharmacology of the agent. And then if there remains uncertainty, there is often a need for some clinical trials, but again, not multiple large phase 3 trials like we're used to. So this stepwise process of approval, starting with analytic studies, through animal studies, early clinical work, immunogenicity studies, and then ultimately some clinical trial data, but far more constrained with the goal of reducing the cost of development of these agents so when they go on the market, they can compete price-wise with the originator, and hopefully that competition will bring down the pricing. So the first biosimilar in the US that was approved in 2015 was a supportive care agent, filgrastim or GCSF. And this was produced, and as you see, a four-letter suffix was attached to this, so it's filgrastim SNDZ. And in this case, it was related to the manufacturer of the product. We'll get back to the complex terminology that's evolved since then. But this was the first biosimilar. Now, there was another filgrastim approved prior to this, but there was not a process in place established by the FDA for regulatory approval. So they went through a traditional new drug application process. So that's a product, the tibofilgrastim, which is approved in Europe as a biosimilar. In the US, it's an originator, just like the original filgrastim. Since then, though, there have been several additional supportive care agents that are approved. We'll take a quick look at. But the important thing here is this first biosimilar had the same protein, primary protein structure, amino acid sequence. The mass, size, charge, characterization of this molecule is essentially the same as the original biologic product. It clearly had the same mechanism of action by binding to the GCSF receptor on neutrophils. Pharmacokinetic and pharmacodynamic characterization, and there was no difference in immunogenicity between the biosimilar and the originator. There was a phase 3 trial done in a small number of breast cancer patients getting TAC chemotherapy that demonstrated no meaningful differences in efficacy or in safety characterization, toxicities, or in immunogenicity compared to the originator. And additional phase 3 trial was done. This was the first one out, so they wanted to provide additional clinical data, and there's been retrospective studies done subsequently to confirm the efficacy and safety and similarity of this product. So the first biosimilar is out. Again, it's a supportive care product. It's not a cancer treatment per se. But there's several aspects of the regulatory process the FDA put in place that are very important to understand. And this has been an education effort on the part of ASCO, American Society of Hematology, other professional organizations, NCCN, to make sure clinicians understand what's different here than what they've been used to in terms of biologic therapies. One of these is this concept of extrapolation. And the principle here was that the FDA decided if they, for every new indication or every separate indication in the label of a biosimilar agent, if they required the same amount of data, clinical trials for each separate indication, that they would be challenged to be able to drive down the pricing of these agents because they would be obligated, the company would be obligated to provide the same number of clinical trials for each separate indication. So they formed a policy and put in place, and this has actually been replicated in several biosimilars approved since that time, that if an agent is approved as a biosimilar for one primary indication, in the case of this biosimilar filgrastim, is for reducing the risk of febrile neutropenia, that there would not be additional data required. At least the FDA would have the discretion to extrapolate to other indications of the originator product, in this case, again, filgrastim, for the other indications, some 10 in this case, that had been granted over the years for the originator product. So what's required? The company, after getting their initial biosimilar approval for one indication, has to provide some convincing evidence to grant extrapolation based on the mechanism of action, the eligible population, would there be any reason to think toxicities would be different, and so forth. As a result, this first biosimilar was approved on the basis of reducing the risk of severe neutropenia in patients with breast cancer, but based on the regulatory process, it was granted extrapolation and approval, and you'll see this in the label, for all the other indications that the original filgrastim was given. And of course, this is some concern because there was not separate data for all these other indications, like the treatment of severe chronic neutropenia or progenitor cell mobilization and collection. But nonetheless, the FDA has granted an extrapolated approval for these other indications based on the principles that they have put in place. Another concept that's somewhat foreign, but actually is not new, and that's that biologics in general, and biosimilars included, are subject to variability, or what we call drift. That is, as there are minor changes in manufacturing or in the components as a part of the complex process of developing and producing biosimilars, they may change over time as new manufacturing facilities open, again, or new components come into play. The drug itself, the biologic, may be somewhat different. So it's very critical and of course reassuring that the FDA and the EMA, the European Medicines Agency, have put in a process of monitoring these over time to assure that any changes that have occurred because of drift have not affected the critical sites of these molecules and the mechanism of action in both its clinical efficacy and the toxicities that emerge. But this, of course, requires continual monitoring, and I would emphasize, as highlighted in the bottom here, that this process of variability or drift is not unique to the biosimilar product, but is also true of the original biologic. In other words, we don't like to think about it, but the Herceptin that was approved 20 years ago by the FDA is not the same Herceptin that's sitting on the pharmacy shelf today because of minor changes. But we can be assured that it has been monitored and there's been no evidence of a change in the efficacy and safety of that product. But it applies to both the originator and the biosimilar. Again, these are complex proteins. They have the potential for causing antibody formation. Of course, this becomes particularly concerning if it's a neutralizing antibody. If it could lead to a loss of efficacy. It could also cause an immune response, which in some cases can be quite severe. So it's essential not to show that they don't produce antibodies, but there's no greater immunogenicity with the biosimilar than with the originator. And there has to be some clinical head-to-head comparison to look at that specific issue. And then there's this issue of nomenclature that I mentioned. I mentioned the first biosimilar it was somewhat intuitive in terms of knowing who produced it and so forth. But then the rules are put into place to saying that the naming of these, so that they can be tracked in the post-marketing period, you want to be able to distinguish one from the other, will be based on adding a non-proprietary suffix to the originator terminology, the non-proprietary name of the reference product. Add the suffix to that by a 4-letter suffix devoid of meaning, non-related to the manufacturer, and of course make sure it's not already been issued so that there's no legal barriers. So you have the core name, which you'll be familiar with, and then this FDA designated suffix. Of course, this gets a little confusing when you have multiple biosimilars with all these four-letter suffixes. There is a new process coming along, and yet it's not in place, at least it's not taken effect yet, and that's this concept of interchangeability or substitution. And the idea here is that the FDA wanted to set up a process for a higher level of approval beyond just being designated a biosimilar. And this would be a biosimilar that could be safely and efficaciously interchanged with the originator or with other biosimilars. So they've put in place regulatory process, a regulatory pathway with additional clinical trial data that would be required. So if a biosimilar company wanted to have this higher level of approval, so that perhaps clinicians at one institution using one biosimilar or one biologic form that's different than what the patient had been receiving could feel comfortable switching from one to the other. So, and the way this has been put in place, that if a biosimilar received this interchangeable designation, the FDA said, then a pharmacist should be able to switch this to the biosimilar without notifying the provider. Well, of course, this concerns many of us, and it's concerned many states, and there are now nearly 40 states that put in places to preempt that process to say an interchangeable drug can't be interchanged without notification of the provider. You can't, the states can't stop the process from taking place, but they can block this idea that the provider wouldn't be made aware of the interchangeability. So there's not yet an interchangeable biosimilar in the marketplace. In fact, no company, to my knowledge, has actually applied for that process, and we now have these state substitution laws in place just in case this comes to fruition. So it's something to put in the back of your mind, but is not yet something in practice. So just quickly summarize where we are with the biosimilars. We now have, as I mentioned, the original supportive care products, in this case GCSF. So you see the originator reference product, filgrastim, that one that was approved as an originator but is a biosimilar in Europe, the filgrastim, and then two biosimilar forms of filgrastim. We also have the pegylated filgrastim, again, supportive care product. We have the reference product, the peg-filgrastim, and then two biosimilar forms of peg-filgrastim that were approved this past year. And we also have just approval of a Poetin alpha biosimilar. These have now been integrated into guidelines, so the NCCN guidelines for myeloid growth factor use now say that you can use any of these. The panel reviewed all the data from the FDA and from the companies, looked at the safety efficacy data, reviewed the regulatory approval process, and basically said, clinicians can use any of these products. If you feel a patient, for instance, at high risk for febrile neutropenia, receiving chemotherapy, should have a growth factor prophylaxis, you can choose any of these agents. So they have been integrated into guidelines, ASCO guidelines as well. So what's been the uptake or the impact? Again, the first biosimilar approved in 2015. We have very little data on the utilization of these, but what we do have would suggest, at least for supportive care, these products are being integrated into practice. And those of you who are clinicians in oncology probably are aware of what your own institutions have done. in terms of perhaps migrating to biosimilar forms of filgrastim. And you see this study was in JAMA recently, but still looking at data that's a couple years old. You can see that about half of the use of filgrastim in the U.S. By the end of 2016 had gravitated to the biosimilar forms of filgrastim. So it's meant competition has effectively entered the marketplace for these agents in oncology. Now, what the impact will be on pricing and on cost is yet to be determined. We have one small study. It was a research letter in JAMA Oncology late last year that looked at, again, data that's a year and a half old at that time. Perhaps a little bit of impact on pricing. The filgrastim SNDZ, which was the original approved biosimilar form of filgrastim, has been priced about 10% less than the originator, but not nearly the impact that generics have had on pricing in terms of competition, with 70 to 80% reduction in pricing. But I would emphasize we're very early in the process. So stay tuned, and we'll see if it really begins to have an impact. But again, the early results would suggest perhaps a small impact on pricing. And the European experience is that the more biosimilars in a class of drugs, the greater the impact on price reduction that one would expect to see. Well, we're now in the era where it's not just supportive care products, but we have biosimilar forms of cancer therapies. And you see where the patents have expired on many of the biologic products that we're all familiar with through the last year or two. And so we now have biosimilar forms, not only of biosimilars shown at the top of this chart, but several monoclonal antibodies approved by the FDA. Now, some of these haven't made their way into clinics or into pharmacies yet, but they are coming very shortly. So we have biosimilar rituximab. We have 4 now, as of last month, 4 biosimilar trastuzumabs, a biosimilar bevacizumab. And I would emphasize again, there are dozens of these highly similar products coming down the pipe that you're going to be seeing in the next few years. Ali, one of our colleagues at the Fred Hutch and SCCA, indicates that India has approved a trastuzumab, and they've seen tremendous reduction in prices there. Whether that will translate in the U.S. marketplace, though, again, I think we need to follow and see what happens. So here's where we stand at the moment. Since 2015, you can see all the approvals that have come over the last 12 months of biosimilars. The oncology ones highlighted in red. So biosimilars are here to stay and will be having a major impact on oncology care. Having said all that, and just to close, obviously we have some concerns. And as I lecture on this around the country, we give educational programs at the major meetings, I hear from physicians skepticism about the process, about being asked to use these agents with more limited clinical data at the time of approval, uncertainty about whether they really will drive down the price of these drugs and how much of an impact there'll be on cost, and yet they believe that cost is at the heart of the issue, and they're being forced to use these either by their institution or by payers. And so I think it's important to both be skeptical, but also be fully educated about what these products are, what the regulatory process is, and for the guidelines, or the professional organizations as they generate guidelines, to look very carefully at the data. In the recent update of NCCN, we had one of the new pegfilgrastim biosimilars that had not been, none of the data presented at the FDA had been put in the public domain. They didn't have an Oncology Drug Advisory Committee, and they hadn't published any of the results. So initially, we were totally in the dark why the FDA approved this drug, because it was all done behind closed doors. Well, we eventually were able to get access to that data, but initially we said we can't recommend this product in the guidelines if we can't see the data. So my message and our message back to industry and to the FDA is transparency. It's essential that clinicians see the data, the clinical trials, the preclinical data, if we're going to be expected to not only accept the approval of these agents, but integrate them into our practice and prescribe them in our patients. The European experience, though, is very reassuring. They're about a decade ahead of us in this. They've approved, this says 25, now more than 30 biosimilars in the EU. And over that decade or more of experience, none have been removed because of concerns over toxicities or loss of efficacy. No red flags have been issued. So I think that experience is very reassuring. The EMA regulatory process is different, but quite similar to the FDA. So, and there's a lot of interchange between them. So I think we can be somewhat reassured by the European experience. There is one caveat, though, to this, and this was data presented at ASCO this past year, which is even in the EU, the uptake and utilization of the cancer therapy biosimilars, not the supportive care agents, but the actual cancer therapies, has not been uniform across our patient populations. And the experience that was reported from several European countries had to do with rituximab in patients with non-Hodgkin's lymphoma. And what they saw was that clinicians in Europe are more likely to use a biosimilar version of this molecule in patients with low-grade lymphomas or not necessarily being treated for curative intent than they were in patients with high-grade B-cell lymphomas where their treatment intention was cure. And you can see that kind of illustrated here. So it seems, and whether this will be the same in the US, I wouldn't be surprised that we will adopt these agents but not perhaps use them in the same patient populations, the same patient subgroups, until we gain some real experience and comfort with the use of these agents. So that's something to kind of watch over time. So impact on cost, well, this is the theoretical impact we could have. So we could potentially save the US healthcare system $50 to $100 billion over the next few years. Depending on the price impact, the price reduction, illustrated here is a 20% decrease, a 30% decrease, or 40% decrease. Obviously, the greater the price reduction at the time of pricing of these biosimilars, the greater the impact on overall health expenditures in the U.S. marketplace. But this is yet to be seen. As I said, the early indication is we have a small impact, maybe about a 10%. But again, now we have multiple biosimilars in both supportive care and direct cancer therapies. And again, depending on the price relative to the reference product, we will probably see some reduction in healthcare expenditures. But will it really bring down healthcare costs in cancer, or are we just bending the cost curve down? And where this will leave us, and again, as I said at the beginning, I would just emphasize this is only one piece of a very large structural and programmatic challenge we face in oncology in terms of overall healthcare expenditures. Just end with an effort out of ASCO that I was privileged to chair this past year that was published in JCO, trying to cover all these issues we've just gone through in terms of educating, make sure our colleagues are familiar with the process, the regulatory process, and what's involved here, how these are named and approved, and why we're doing this. You know, it has to do with pricing. It has to do with perhaps improving the value of cancer therapies by lowering price, but making sure the quality and the efficacy and safety of these products are maintained. And in the end, we need to find the proper balance between approval that requires too much data, which means you're probably not going to lower prices and provide cost competition, even though we may be more comfortable with that because of our experience with the originator products, or not requiring enough data, in which case the uptake and utilization and integration of the guidelines may be compromised because of continued skepticism or concern. So I'll close with that point and glad to entertain any questions. Thank you.
A question or two. We've already made the executive decision to cancel the break, so we're buying a little bit of time back there, but why don't we?
Sure.
Thank you, Dr. Lyman, for a very great talk. I had a lot to learn. I might have missed it in your slide, but are there any efforts in terms of validating how these biosimilars are performing in the real market? Because there's kind of a paradox on with regards to how we are dealing with this kind of evidence. I treat breast cancer, and the example that comes to my mind is we're quite cynical about, say, use of capecitabine in high-risk adjuvant breast cancer patients out of the CREATE-X trial that was done exclusively in Japan. Whereas, on the other hand, we welcome with open arms the data on biosimilar, trastuzumab biosimilar, for example, which was done in Turkey or Malaysia.
Yeah.
So there's clearly a discriminatory immigration of evidence, if you wish, in how we deal with products. So any efforts in terms of...
Well, this is why it's so critical, as I alluded to, that when these get approved by guideline panels, reviewed by all of us as we review the data, that we see the actual data. You know, were they approved in a population? Was there data provided on a population that we feel is representative of the patients that we treat? Again, is the mechanism of action the same, the pharmacokinetics the same? We can't just say, okay, you know, it looks the same, we think it's the same, and necessarily adopt that into clinical practice. And there has to be the transparency where we or the professional organizations that we trust to make recommendations to us have had full access to the data that's provided. I think a perfect example is whether, again, the population that was treated is necessarily representative, or could there be differences that would be impact on the patients that we treat in daily practice. I don't think it's an issue unique to biosimilars. It's one, across drugs that we use. But I think it's the transparency of data supporting these applications has to be fully there. Elaine.
Thanks, Gary. It was a very instructive talk. I've always wondered why the companies that manufacture cancer drugs can't sell them for less money post-patent. I mean, we know that these companies can do it right. That would, if that could be done, we could avoid the costs of all the trials of biosimilars. I mean, and not that I don't think this work is valuable, but a lot of physicians and maybe patients would have confidence in the original brands.
Yes. Well, I'm glad you're going to be on the next panel with me. So, because that's exactly some of the issues we want to get in. I mean, I think most of us, and myself included, would agree with you. If we had some way to constrain the pricing on the original drugs, there would be less need for and motivation for producing these Me Too agents and relying entirely on the competitive marketplace in a healthcare environment where you have to question whether competition is the best way to solve the problem. So this is the FDA's and the government's answer to trying to address this within the health system we have, which is a market-driven system. But I hope we get into some discussion of whether there's a better way to build a mousetrap to take care of patients in this country. Thank you.
Speaking of motivation, you didn't touch on how Medicare has decided to price and pay for these drugs as motivation for physicians to prescribe them.
Yeah,
well,
you've been involved with the 340B.
No, I'm not thinking 340B. They've priced these drugs so that the margin on these drugs is considerably higher than it would be if they just used ASP by gauging between the
yes.
In the case of the pegfilgrastims, Neulasta price and the actual ASP of these drugs is paid at a higher price to increase the margin. Do you think that kind of pricing is a good thing incentive-wise, or does it just play to our baser instinct?
Well, I actually believe the latter, but it is an important issue, and I think the question is going to be over time whether that will stay in place. And of course, there's discussion among legislators as well as some of our professional leadership at the national level about changing that. I think that the hope was that there'd be some preference to switch to the biosimilars and to drive greater competition here. But it's such a, the contracting that takes place at the institution level, at the provider level, the role of insurers in this, I think makes it, for many of us, a black box as to what's going to happen over time. So, I don't know that I'd call it a good or a bad thing. I'd call it an uncertain consequence of what's going to happen to product pricing and so forth. I think the good news is, again, at least for supportive care agents, we've seen uptake take place and a lot of broad utilization. I think we have no idea what's going to happen with rituximabs and trastuzumabs and the cancer therapeutic biosimilars, because it's a far bigger issue, not only from a cost standpoint, I think, but from for patients and for us as providers, because we're talking about actual cancer treatment, not just supporting a patient and getting them through a neutropenic episode. So yeah, important issue, but I don't think we really know if it's going to work and if it's going to be positive or negative. Probably we need to call it and go on to the debate, unless you want to stay here all afternoon, of course, and then we can do that. So we do have a panel, and I'd like to bring up our panelists. I'm going to have you all come up for this, and I'll do some brief introduction. As they come up, I just reiterate, for those of you who were here yesterday, please just come on, kind of. Those of you who were here yesterday, you heard the debate that took place, which I think was it was extremely good exchange between the panelists. Do we need another chair, or do we have enough here? There we go. Okay, great. I'd probably just stay here, yeah. Thanks. So, as we heard yesterday in the debate, which was far more focused on, again, the U.S. healthcare system on a broad level and the structural challenges we have, we heard that there's some $3.5 trillion in U.S. healthcare costs annually, about 300 to 400 billion of that is for cancer care alone, and as we just talked about, probably about 50 billion of that is for cancer drugs, but enormous challenges from a system standpoint. We also, I think, came to the conclusion within the panel that this is unsustainable. This continues to rise, and left unchallenged or undealt with, we would be going bankrupt as a country, as a healthcare system. But at a more grassroots level, obviously it creates an enormous burden on patients, on their families. It provides an access blockade to getting these treatments, to staying on treatments. And even if patients able to somehow, through mortgaging their home or going into bankruptcy, to continue on their treatment, they're left with this enormous financial burden. And we've seen, again, bankruptcy rates go up. Patients with cancer who go into bankruptcy, our own data suggests that the mortality in that population is greater than other cancer patients. So we have a real large healthcare system challenge. What I hope we can, and we also talked about disparities and the fact that access to these drugs is far from uniform across our population. Today in this, and what I'm going to pose to the panelists here, it won't be so much a debate, but a discussion about the personal impact of the healthcare crisis as it relates to cancer. And, we're going to get into issues like value, so the benefit, maybe minus the harms, but the cost of delivering a certain amount of value. And, as Warren Buffett said, and I think maybe it was Otis Brawley mentioned it yesterday, that cost is what you pay, but value is what you get for what you pay. And I think that's very true in the case of cancer care costs. So ASCO has issued a value framework, so has the European Society of Medical Oncology, trying to put value in the focus. It's not just about cost, it's what you get in terms of cancer care quality of treatment and prevention, and what that costs. All of that is part of the equation. We need to get beyond the rhetoric of that we've heard so much in previous campaigns, political campaigns, death panels, rationing of healthcare. We need to come down to what is really important to patients in terms of the value of treatment that they feel, the impact of the treatment they're being offered will have, and what they think they should be able or willing to pay. So I'm going to frame this, and again, I'm going to ask each to do an introductory comment, but basically I'd like to highlight 5 areas. One is the what. So what threshold or what level, how much benefit should one expect to get for a certain expenditure? Number 2, who? Who should decide? Should it be the government? Should it be the Medicare system? Should it be the healthcare provider? Should it be the patient? And who should decide what that threshold should be? The when. By this I mean, should we look at this differently for a patient who's with early stage disease being treated for curative intent, or versus a patient with advanced disease where your goal is more to alleviate symptoms and extend life, but not necessarily cure for the long term. The how. So how would we actually implement some type of metric or some type of value, and again, would we do that at the time of FDA approval of the drug? Should the FDA only being approving drugs where the value seemed to be above a certain threshold? Should it be done by CMS, again, Medicare, in terms of reimbursement for these drugs, by the payers, by our health systems or our practices? Should we be making that decision as a group, as a professional group? And where does the patient come into this? And how do patients, as perhaps the principal stakeholder in all of this, how should their perspective on where to draw the line and what threshold to use comes in? And then finally, the where, from my perspective, is there anything we can learn from other healthcare systems that have dealt with some of these same issues, and at least in some cases seem to have found ways forward that we have not yet found. So are there examples in other countries, or maybe even at the state level, where we have a process or a way that we might consider using at the national level in the U.S.? So just to quickly introduce, we have Dr. Sarab Jha, who is Sarab here? Yeah, okay, good. A radiation oncologist, I believe. No, radiologist, okay, at the University of Pennsylvania, trained at the University of London, and has been very prolific, both in terms of publications, and I think you have a healthcare blog, if I understand. So we look forward to his comments on this. Dr. Elaine Shatner, I think many of you know Elaine. She's a journalist, but she's also a physician, cancer survivor, and I think holds a clinical associate professor of medicine faculty role at Weill Cornell Medical College. And many of you have seen her commentaries and editorial pieces. We have also with us Dr. Jeffrey Ward, who is a local here in Washington State. Dr. Ward is a medical oncologist, hematologist at the Swedish Cancer Institute, I think based in Edmonds, where he was a graduate of the University of Washington, that we're proud of, and did his residency and fellowship at the University of Minnesota. And he has provided care, has served as medical director at the Providence Hospice in Snohomish County for a couple of decades now. And as you heard earlier, Dr. Ward has been very much involved with cancer care payment systems and reforms, and is current chair, I believe, of the ASCO Government Relations Committee. Also have Dr. Ken Anderson. I think he goes without needing to mention that as a previous president of the American Society of Hematology. He's a professor of medicine at Harvard Medical School, director of the Jerome Lipper Multiple Myeloma Center there, is world-renowned authority in multiple myeloma, and currently Duke Distinguished Clinical Research Scientist and American Cancer Society Clinical Research Professor. So, and then finally, Carla Tardif, who's we're fortunate to have join us here. She is representing the Family Reach, which is an outreach to families to provide financial aid and help them through the crisis that we're trying to discuss as this last session goes forward in the program. So I guess maybe I'm going to start here with Elaine. You sent me some notes, so you feel free to do those. But any of this that you want to highlight, maybe each of you take about 2 minutes, and then we'll open it up for broad discussion. And then I do want to make sure we get the audience engaged in this discussion as well.
Sure. I'm Elaine Shatner, and I've cared about healthcare delivery basically my whole life, and that's largely because I have other conditions, including severe scoliosis. And so I came to the practice of medicine as a patient, and I practiced oncology for a long time. And what I've seen in the past 15 years is so much progress in the field, along the lines of what Dr. Abulafia described earlier for patients with HIV. I see now patients who are living with metastatic melanoma, metastatic lung cancer, metastatic breast cancer, who are surviving far beyond what anyone might have dreamed, even 15 years ago and 10 years ago. It was inconceivable that some patients would be doing so well. Emphasize some patients. And so I come to this with the goal of figuring out ways to provide oncology care and some, at least, oncology drugs to everyone who might benefit. And really that's where I am with this conversation. And I we'll see how it goes. The other thing is that there are no easy solutions, as we heard yesterday.
Thanks, Elaine. So I'm sorry, Chair, I trained in the NHS, which gets a bit of a bad name as being a socialist system that actively rations, which is very far from the truth. But what I wanted to first start off with is an event I remember from my youth when I was traveling in my homeland in Bihar, which is the most corrupt state in India. And I met a civil engineer who told me about a conversation he had with a politician. He wanted a bridge to be repaired, and the local politician asked him how much it would cost. So he gave the cost, and then the politician said how many people would die if the bridge collapsed. So he gave a kind of rough estimate for that. And then the politician asked him what would be the cost of providing relief and compensation for those that died. So he gave him a cost for that. And then the conversation kept going, and the civil engineer then said, the bridge is likely to collapse within 4 years, which is, of course, the tenure of his time he would get re-elected. And he said, if it collapses and people die, you will lose the election. And if you build the bridge, you will win the election. And the rest is history. I think formal cost-benefit analysis, which that politician, as corrupt as he was doing, is something which people find very unpalatable. And the most the biggest example that I have from the United States that comes to mind is the case of Ford Pinto, where they did a very explicit, transparent cost-benefit analysis saying that the 180 lives that would have thus been saved wasn't worth the $200,000 extra per life, or that's what the calculation based it on. And they got their posteriors kicked. And the case I will make, or I'm already making, is that we should do cost-effectiveness analysis. I think there's a lot to be learned from that, a lot to be learned from models and specification, but actually setting a particular threshold for life, whether done by the federal government, whether done by locally, is not something that's going to be palatable to the American people. And that will end up losing elections and causing more problems than it solves.
Hi, my name is Carla Tardif, and first of all, I just want to thank you, Gary and Dr. Sheff, for having this conversation. I am the CEO of Family Reach, which is a national nonprofit. We've been around for 22 years. I've had conversations with a lot of you who are like, why have I never heard of you before? And the answer is because we literally step in and pay non-medical bills of families who deal with cancer. So I'm stepping in and paying rent, mortgage, heat, utility, car, taking care of those basic human needs. As you heard, cancer, wreaks financial devastation on families. Cancer patients are 2.65 times more likely to go bankrupt. Yesterday you heard 2.5, but I think I'm going to just be really accurate here, with a 79% higher mortality rate. So all of this great work, all of these breakthroughs, all fantastic. I am a cancer survivor as well. But when patients can't access care, cannot adhere to treatment, what's the point? I mean, we're not looking at the whole picture. Cancer affects the whole family. This is not just about the patient. So when we talk about value in care and we look at these frameworks, they need to include what is the patient's family makeup, what is important to them, what are their finances, because that is part of the treatment. So what I'm hoping to get to today, and by the way, I will not say half of what I want to say because there's not enough time. So I invite all of you to ask me any questions later because I'm here to help you in your practice. If you are a pharma company, I know you have resources for patients that aren't being utilized. I am a direct link to the patients. We are in the trenches, so I really want to talk about how I can help all of you reach your patients. But thank you. It's a really important discussion.
Well, my introduction to all this has been through ASCO leadership, and I was my first real experience was with ASCO's Clinical Practice Committee at a time in which Congress was considering making dramatic cuts to payment for chemotherapy drugs to oncology, and we got pulled into the super committee's staff office and said, what can you give us if we aren't going to cut to ASP plus 2%? for what we pay for chemotherapy drugs. And we went back to the drawing board and began working at it, went back to them and said, we can't give you anything. And the reason was we weren't prepared to have that discussion. So I've spent the next 8 to 9 years in ASCO working on payment reform and trying to get to a point where we can have that discussion. You asked who should be responsible. I think that with cancer care, you have to cut the responsibility into two parts. I don't think that as oncologists, we should be responsible for the sticker price of the care that we give, but we should be responsible for the utilization. So I think it may be the government's job and payers' jobs to incentivize us in a way where it is easier for us to do our job and to still make a living and to keep our hospitals' doors open. But I think that when it comes down to trying to decrease the utilization of the drugs that we use them appropriately and not use them indiscriminately, that's our job. We should take ownership of it. And I don't think that right now we do.
Okay.
Yes, I've been very blessed to be part of treatment of hematologic malignancies that has been transformed over the last 10 or 15 years. People are living in myeloma, which I work on, for 3 or 4 times longer than they did just a short time ago. So that's the good news. But as this meeting has illustrated, for lots of reasons, there's disparity in who has access to these advances, and we really can't make science count for patients around the world, but in the US as well. And, you know, crying out for reform in the system in many aspects, as has been illustrated in the beautiful talks here. But I think the one point I just want to mention to start out with is the focus is the patient. And I think what we need to remember is we need to make these advances count for the patients and their families, number one. And number two, we need to treat patients as we would want to be treated. And I think if you remember those two tenets, then the kinds of issues around reform and other things will actually fall into place. It's still very complicated. But I'll just cite one story I'm remembering right now. When a novel therapy comes, and that for whatever reason, a patient who actually has insurance in our country gets denied insurance. So then we go through this process right now that highlights why we need reform, where we, as oncologists, take responsibility and talk to levels of people about the appropriateness of a treatment for somebody where there's actually an approved treatment that will help. For whatever reason, it's being denied, and I've had this experience repeatedly, and we eventually get to the top person who tells me that they really can't cover this care. We're very sorry. And I always use at the last gasp, well, can I ask you a question? If this were you or your loved one in your family, would you actually want this treatment for them? And the answer universally comes back, yes. And I tell them that they've forgotten that they're a physician. And the point is, this system that we have right now in terms of a delivery and making sure that actually novel therapies and really therapies that work get to patients is badly in need of reform. So the value concept you're talking about and cost, but the value is something that we all would want for ourselves. That's the value. And then we can determine how we're going to pay for it. But I think I want to make sure that we focus on doing the best by the patient first and foremost.
Great. So feel free to react to what anybody in the group has said. Elaine?
So I think value is in some ways a dangerous concept. We heard earlier about AZT and how when that was first prescribed to patients who had HIV or AIDS really in the late 1980s, some people thought that the government or doctors were trying to kill them because its value as a life-saving drug was so far from obvious. In cancer, I was at a talk by Dr. Eric Weiner, who is really an expert in breast cancer care, and he referred to the first paper in the New England Journal of Medicine in 2001 about Herceptin. And basically it showed just 3 months of progression-free survival benefit in patients with metastatic disease who received that drug by its brand name. And if we had talked about that benefit now, 3 months of progression-free survival, we would have said this drug is not worth the cost. And so my concern is that in assigning value prematurely or sometimes wrongly due to how we analyze things, we may be precluding patients access to drugs that may be life-extending and life-saving and may improve the quality of life. So I think when we talk about value, we have to do so very carefully. What's valuable to one patient may not help another. If 5% of patients respond, the drug may be useless to most patients, but extremely valuable to those 5% who do respond. And how to capture that data and represent that to the public, I think, will be crucial for preserving access to those drugs.
So I do agree with Elaine with the concept of value. I would also add that value is also not static, it's dynamic. So something as treatment gets better, selection gets more refined, the value increases, and analysis based on cost-effective analysis tends to be static, or at least to refine them or to revise them, the process is quite laborious. But I'll give a couple of examples from the National Institute of Clinical Excellence, both to illustrate how having a threshold doesn't necessarily mean that that systems won't get bankrupt. So Sovaldi, as you may all know, is a very expensive drug, priced, I believe, at around $84,000 for a course of treatment. But even at that price, even with all the economic analysis that National Institute of Clinical Excellence did, they found the drug to be cost-effective. I believe it was less than the $50,000 threshold that is conventionally used. And despite that, despite the fact that they found it cost-effective, and despite the fact that they find a lot of things cost-effective, such as screening for liver cancer, when they do find it cost-effective, it still breaks the budget of local healthcare authorities. Because what NICE does is only the cost-effectiveness analysis, not the overall burden of the purse. And so you have the twin problems with this threshold. One is that there's nothing magical at 55,000 or 60,000, nothing magical of 50,000, a historical accident from dialysis, based on the fact that dialysis was much contested as being something that should be offered. But the second thing is that even if something is cost effective, it doesn't mean that it won't be costly. And so, it's a very complex thing to resolve. But I don't. But my point, I'm going to sound like a bit of a broken down record, is I don't think that we should specify a cost for life.
I guess I'm not a doctor, so I'm sitting here thinking in the patient's perspective, and I'm wondering what the conversation is. A lot of the families that we work with, we ask if they're talking to their doctors about cost, and if the doctors are talking to them about cost. And from where we sit, that conversation is not often happening. And I'll tell you, when it's a parent whose child has cancer, they will stop at nothing to save their child. So they're not asking about cost because they don't want an inferior product or any shortcuts. So they're not bringing this conversation up. Those are the families that I'm getting out of homeless shelters and families that are now living in their car. They have health insurance. They're just afraid to talk about cost. And then there's the adult population who may or may not ask about cost, but I'm seeing parents opt out of treatment because they are bankrupting their family. I had a single father in Boston, 1 child in college, 2 in high school, and he said he started eyeing his high school kids' college savings to pay for his treatment, and that's when he decided to opt out. So I'm just wondering if where the patient fits in this conversation and if it's being had.
Well, I had 2 patients this last week with metastatic breast cancer that were new to me. One of them is 99 years old. Her breast cancer has recurred with bone disease and pleural effusions. 10 years after her initial diagnosis, ER positive. We had a discussion about treatment. She has good bones. We decided we would start exemestane. And I said, now there's this new drug called palbociclib that some people think we should give up front with it because it works better than giving it later on. Your mom's 99. The patient was a little bit demented, not a lot. And she listened to it, and I said, Medicare will pay, your Medicare Part D will pay for some of this drug. There is likely to be a 20% copay, and we can work on finding foundation funds for you. If you want to do that, this is the way we have tended to treat this disease. And she said, my mom's 99. I don't know why we would want to do that. Mom, do you want to spend $10,000 a year on a drug? And her mom said no. And we stopped that conversation. The other conversation was with a woman who has had metastatic breast cancer for 3 years with brain metastases. I'm her third oncologist. My impression is that she has changed oncologists 3 times because each doctor has lost enthusiasm in treating her mom's disease. She's an immigrant. She says, I have to be able to stand before my maker and say I did absolutely everything I could do to keep my mom alive for as long as possible. And if you won't treat my mom, I will find somebody who will. If I have to go to China, I'll find somebody who will. And they're and her mom is in a tilt chair because she's had a stroke and she can't use her legs and she's performance status of 3. 2 very opposites. I'm struggling with how much do you let patients decide what their treatment should be after you've given all of them the information that you think they need.
Yeah. Any thoughts, Ken?
Make a quick comment. If I think this is all very sanguine. I think the reason this argument is really gaining much more notoriety is the cost of the drugs now. When we treat a blood cancer with 3 drugs for a year, it's $600,000. We have clinical protocols of CAR T cells that are approaching $1 million in treatment, $500,000 for the product and $500,000 in the hospital and other stays. And in our setting right now, the benefit's about 1.5 years. So we've had beautiful talks during this meeting about how, the healthcare cost is exceeding the median income per month. But we haven't seen anything yet if we start to talk about this kind of cost. So I do think it's so essential when we sit and talk with patients that we actually do have a much more very down-to-earth talk about what this treatment is and what is actually the cost. And I think, that the system is in great need of reform. But I think right now, too often there isn't a talk that considers the actual cost of the product. And cost is dollars, but cost is in the lives of the family, the bankruptcy and other changes. So I think we really do need, as oncologists, to not only talk about the medical side, but be much more sanguine. Sometimes we don't even know what the actual cost is, but we really do need to be, as the patient's advocate, helping them in every aspect if we can, the medical aspect and also what is going to be the impact on you and your life.
So it sounds like we could all agree a starting point is going to be maybe not the first thing we talk about with patients, but at some point in the conversation, making them aware of what the cost implications will be of what we're recommending to them, or what the differential costs are of options if we feel there are different options. And yet the reality is, as I think a couple of you mentioned, is patients are reluctant to bring up the cost issue for fear that the doctor will alter the treatment or not give a treatment because of the cost when they want everything done that can be done. So I think, clearly there needs to be a message, and I know ASCO and other organizations have highlighted this, that physicians need to listen to patients, but also they have to have these discussions at some point about the cost. And as you mentioned, Ken, and I think this certainly was true of true of me, and I think it's true of many of us, we often don't even know what the cost is. We click on Epic and we order things, and in some cases maybe we do know, we've looked at it, but when we order a PET scan or a CT chest, abdomen, pelvis, do we really know not only what the charge will be, but what's going to filter down to the patient because of the complexities of contracting? We don't. And it's really hard to have those. You can talk in very generalities with patients when they ask those questions, and usually my strategy is to get them to a financial counselor who can hopefully dive into their coverage and maybe have a discussion with the payer, but it's extremely complicated. And I think that poses, and of course, in the end, we have so little time to have those discussions with patients because the focus is on, curability or response or side effects of the treatments. And then usually it's at the very end or not at all where the cost issues come up. Right?
This will be a controversial statement, and we're asked to get the audience involved, but I think the point you raise is very important about physicians bringing up costs, and I'm a member of ASCO, but I don't believe that physicians should, certainly not in an ideal world, for reasons first of time, that the oncology care is complicated and there's so much to discuss about diagnosis and treatment options. What we should be aspiring to, I think you asked about the who, but I think it's a societal issue of who and how we pay for cancer care, but that the cost issue needs to be resolved outside of doctors' offices so that patients shouldn't feel that they need to or ashamed about bringing it up, and that doctors don't have to spend their time and even their brain power knowing about the different drugs and how much they cost if they could know that much. I think that these are really key issues, but for society to decide. I also think about futility. Physicians should be able to say, that treatment isn't appropriate, it won't help, and I cannot give it to you. That's a hard thing for a doctor to say, but sometimes it does need to be said.
I actually completely agree with you. I think the conversation needs to happen. I think it's the who and the when is another conversation. I had the opportunity to shadow a pediatric oncologist at All Children's in Tampa. And she explained this case we were going to go see, and it was a little 6-year-old boy with Down syndrome who had a brain tumor. He was diagnosed when he was 4. He had had radiation, chemotherapy, surgeries. The tumor was growing, and we went in to have the conversation about what was next. So the doctor very focused on curing this little boy sitting in his dad's lap, squirming around, and the mother says, "I'm sorry, we left the house at 4:30 this morning, so we've been up for 5 hours." It was 10:30 in the morning. So I'm thinking, okay, that's, what did that cost and what is that doing to the family? The doctor went on to talk about a surgery that needed to take place. There was a surgical team waiting to meet with them next on the 3rd floor. The father asks, how long is that going to take? Because we have 2 little girls that get off the school bus at 2:30 that we have to go back and get. But the doctor's not here. So I guess what I'm saying is I saw and heard an entirely different side of cancer than the doctor was focused on. So there does need to be a point where you're empowering the patient to speak up, but I think it's to a social worker or to a navigator or to somebody who has resources and knowledge. So what Family Reach does now is we've got these wraparound services that we are using the social worker, the oncology social worker, as the front line. I understand it's not perfect because not every patient knows they have a social worker. Not every institution actually has social workers. But we have 440 hospital partners. The social workers have now a financial handbook that they're giving to patients that we produced, 5 patients and caregivers, 4 patients and caregivers, that says finances will likely play a part of your cancer journey. Here's what you need to know. It wipes out the shame. It lets them know this is what a majority of the patients deal with, that you can ask questions. You should come to the social worker. You can certainly call Family Reach. So many of the drug companies that we work with say, we have drug assistance programs. Why aren't they using them? They don't know about it. So there's also a communication gap between the patient and the resources that are available, which is what Family Reach does. We also offer additional financial navigation, insurance optimization, copay. We direct them to copay assistance and drug assistance. And we don't just hand them or send them a link to say, on your own, go figure this out, maybe there's help. We do it with them, we do it for them. And we give them pro bono certified financial planners that go through a Family Reach training module. So early on, they can sit and say, how much income are we going to lose because of this disease? And what are our out-of-pocket, projected out-of-pocket expenses? And how are we going to help you get to the other side of cancer without having financial barriers get in the way of access and adherence? And take out some of the, I feel so bad for these social workers who are completely overwhelmed. They are not trained in finances, yet most cancer patients say that the financial concern is more than the cancer. Because cancer, you have a care team, you have specialists. For the finances, there's nobody. So awareness, education, communication, just bridge the gap so that patients have somewhere to turn.
Yeah, and you make a very good point that the cost implications here are far beyond the bill that they'll get from the doctor's office, and often quite unique to each individual patient and family.
Yeah, so it seems there are two major issues. One is the finances to the individual patient, and the other is the cost to the whole system, like cost of healthcare as a percentage of GDP. I think the latter, we fear it, and at least one economist believes we shouldn't fear it that much, and that's William Baumol, who wrote a book, The Cost Disease, in which he said that healthcare as a percentage of GDP can go higher, and in fact he goes on to say that it should go higher, and it's not a problem, even if it goes to 30 to 40% of GDP, as long as the other 60%, the productive part, the one that doesn't suffer the cost disease part, is cheaper. Like the phones become cheaper, the food becomes cheaper, and so on and so forth. So I'm not going to go into the weeds of that particular argument because it's a very deep economic argument and lots of to and fro. But I think that the issue to the individual can be solved by better redistribution, by better ways of actually having more redistributive co-payments so that it's not all lumbered to the sick. I'm not sure if single payer is the issue, but I think there are two things over here, and the cost to the system may not be as prohibitive or as crippling as we might think, particularly if healthcare, in addition to that, becomes a driver of jobs and an economic stimulus.
I might ask Jeff and Ken, where cost, in your own practice setting, where in the process or who is likely to bring up the cost issue on patients that you're treating?
Well, I often do. We also have a financial counselor who actually sits down and goes through the nitty-gritty with them. We have social workers that are working on kind of, how are you doing with your own personal finances, which is different than how much is the cost of this and what your copay is going to be. My concern is that I think that there are many physicians who would rather turn that over to somebody else and pretend they don't need to talk about it or know about it or do anything about it. When I send a patient to my palliative care doctor, I know that they're going to say things to them that they may not say to me because they're afraid that it will impact my recommendations for their care in a way that they may not necessarily want. But I read those notes. I go through that information. I know what they've said to their palliative care doc, and I can then broach that topic with them. When they go and see the financial counselor, none of that gets documented.
Yeah.
The social workers, they write notes, and I have a sense sometimes from that what's going on at home. But I think that we have the ability with our computers and everything else that the doctor should, with a click, be able to know what the patient's deductible is, what their copays are likely to be, what the cost to the patient's going to be of a care. Not that they have to sit down and do that with them, but they should know that information. When the financial counselor sees them, there should be a note in the clinical chart that says, I had a discussion with a patient. This is what their cost is going to be. Because I can't really advise them about their care without knowing that information. If I abdicate that to somebody else and pretend it's a black box I don't need to know about, I don't think I'm doing my job.
Ken, how about at Harvard?
Yeah, no, I totally agree with that. I don't think doctors are experts at this by any stretch. I think that NCCN guidelines now, for example, are ranking the different treatments not only by efficacy and level of evidence, 1, 2, 3, 4, but on also relative, to the cost. What is the judgment of this physician panel? I'm not sure they're qualified, but that's being done. I think of it, Gary, to be honest, we are the patient's advocates. At least I think if we're doing our job correctly, we are. So a couple interactions happen. Sometimes patients who have been on drugs for years will come in and talk to it about cost because the drug has increased in cost 2 or 3 times in a year, and they've been on it for 10.
Yeah.
And now it's starting to really hit home in terms of, making a difference. So in that case, I'll be an advocate. I'll talk to the patient about it. But to be very honest with you, I will go, because I'm old and been around for a long time, I will go and talk to the very high ups in the pharmaceutical companies about, why are you doing this? Do you know what you're doing to the families? They are actually experiencing pain, real pain, for these increases that have happened. But I think, so that would be one that a patient might bring to us. I think, just as you mentioned, I also would bring it up, not pretending to be an expert, but to just talk about it so they're aware of what they're getting into. And the timing of it is important. If somebody comes in with a new diagnosis of cancer and you spend, which we really do need to spend an hour or more with the patients going over things, be surprised how many times they'll say, you're the first person that ever did that with me. But in any event, spend some time, go over what they have and pluses and minuses. But, that may not be the best time to also unload another whole episode of the financial toxicity. I'm not saying to be naive about it, but it may be on subsequent talks, et cetera, that it'd be better that they've got enough to deal with. But I think that we need to introduce the discussion as the patient's advocates and then people who are more qualified, at least in our system right now, the financial counselors at our centers. But what they end up doing, honestly, is trying to solve in terms of already what the cost is to try to meet the cost. I'm maybe naive, but I'm trying to be more than that. I would like to do something about the cost that maybe physicians can play some significant role in.
So obviously we don't have all the answers here, but we know you folks do. And we'd love to have some comments and contribution to this, either questions but also ideas and your own experience and practice when it comes to the issue of healthcare costs and the patients that we serve. Ali?
Thank you all for all the thoughtful thoughts. It's been excellent. I'm Ali Kaki. I'm a HEMONC fellow here at the University of Washington. And I just have a few thoughts and a question as part of this. Yesterday Dr. Brawley spoke thoughtfully about how we need culture change within medicine and how a lot of the gluttony and a lot of the excess in medicine is part of the problem is us doctors, which I took to heart. And I was thinking about a little bit over a year ago, there's a New York Times article titled Desperation Oncology, where Oliver Sartor had advocated that no patient should die without receiving a treatment of checkpoint inhibitor. Talking about how these new novel therapies, we don't know who they work in and we should be using them in everyone. And recently we've had there's an article that was published that showed high utilization of checkpoint inhibitors in urothelial cancer. Dr. Gyawali had a thoughtful piece recently published highlighting how patients with poor performance status with checkpoint inhibitors, we don't have good evidence, we have paucity of evidence of whether they actually work or not. So sort of taking that all into consideration, I've been wondering a lot about when is it appropriate to use these medications. And Dr. Ward, you're talking about how much do we need to decide what is appropriate treatment and what's not. And Dr. Shatner, you mentioned we should be sort of participating in that role of what is futile care, what's not. So I'd love to know what some of your thoughts are about sort of, those questions specifically, especially with this question, especially with the checkpoint inhibitors and novel therapies. Thank you.
I recently reviewed a paper for JOP that was looking at a big academic institution that has a palliative care unit and an oncology rehab unit. And what they were saying was that their palliative care unit census and referrals had dropped dramatically, and their oncology rehab unit referrals had increased dramatically. And they were attributing it to people hoping that they would get well enough to be able to get more therapies, particularly checkpoint inhibitor therapies. And then they looked and said, of those patients who went to oncology rehab, only a very small fraction of them ever did. But just shows, I think, that we are, to some degree, allowing our patients, and I'm saying that deliberately, allowing our patients to practice desperation oncology.
Other thoughts? Yeah, thank you, Ellen. Yes.
Hi, I'm Kelly Shanahan. I'm a former OBGYN and a current metastatic breast cancer patient. And I think there needs to be education on both sides. I think every single oncologist periodically should ask every single patient, what is your goal for treatment? And that answer may change. When I was diagnosed metastatic, my daughter was a sophomore in high school, and I would have done anything to see her graduate from high school. I've achieved that goal, and as my daughter gets older, I come to the point now where I will not bankrupt my family because my next logical line of therapy will be a $13,000 a month CDK4/6 inhibitor. And it's also incumbent upon patients and advocates such as myself to educate patients to bring this up with our doctors. Because often as patients, and having been on both sides of the stethoscope here, patients, we don't want to piss off our doctors because we feel it will affect the quality of the care we receive. So a lot of times we don't question things. And the situations that you've mentioned with the daughter coming in and having, wanting to do everything for her mother in the wheelchair, you're not getting the patient's opinion there. You're getting a family member's opinion. And sometimes it's impossible to get the patient's opinion.
I got an interpreter, and I got her opinion, sort of, but daughter's still in the room.
Yeah, yeah. As a gynecologist, one of the things I always did with my adolescent patients was I would sit them down and say, or the mom was always there with them, one time the dad, I'm going to ask you some exceedingly personal questions. Do you want your mom in the room or not? And whatever you tell me is between you and me. And that's an uncomfortable position. And boy, I got called every name in the book for that. But I think even as oncologists, when you have a situation with families like that, you can turn to the patient and say, would you like your family member to leave so we can have an open and honest conversation? But ask your patients what their goal is, and we as patients need to be clear in expressing what our desires and goals for therapy are.
Thank you, Kelly. I think that's a very excellent point, and certainly one that needs more of our primary attention. That is establishing early on and maybe updating over time what the goals of care are as the situation changes. Yes.
Hi, my name is Daria Kizup, and I'm a hospitalist working up in Providence Hospital in Everett. And I just wanted to draw some parallels between kind of the financial burden of care and also palliative care. We know, for example, that a lot of patients are hesitant to talk about prognosis to their doctors, but yet they would like their doctors to bring it up themselves. And I was just kind of thinking that with financial difficulties, it might be similar, where patients are hesitant to bring up these issues because they're difficult, but they're kind of hoping that maybe the physicians would bring it up themselves. Because I work as a hospitalist, my picture of oncology is a little bit different than outpatient. Patients are sicker, and I've had a lot of patients where when I talk to them about the big picture for their health, At first I was scared to do it because I thought it might make them upset, but I found that if I asked them first, is this something you would like to know about or talk about, a lot of people are very open, and later thank me for kind of talking about the big picture with them when other people have not. And I wonder if with financial issues, we as physicians have, a similar hesitancy. We don't want to upset the patients, or we think it's beyond our scope, but I think maybe asking for permissions or asking, are these things, is it something that people would like to talk about, would like to hear about, would like some of our help and guidance, I think are important conversations to have, just because it has such a big impact on quality of life. So I think since we're trying to take care of the whole person, I think it should be part of what we're taking care of. And I know as physicians, we've been trained to not take money into account and to just use the best treatments and not think about it. But I think that's, I think that paradigm actually needs to change, because for example, I have had one patient who refused treatment for cancer because the first treatment bankrupted him and nobody told him, and he ended up being in a shelter, and the second time when the cancer recurred, he just didn't want any treatment at all. And I was thinking also that the system needs to change to make it easier for doctors to be more transparent with their patients, because even the financial cost of treatment, it takes days for the social worker and for the insurance company to come up with that cost for us to be able to have a conversation. And I wonder if both as physicians and patients and advocates, we need to advocate for more transparency in the pricing so that we can help our patients more and take care of the full person and their families.
Yeah, thank you. Any thoughts?
I think you said something real important. I admit patients to the hospice unit that's in your institution, and this weekend I forgot to put it on the calendar, so I've been on call at my institution. And I think being a hospitalist and bringing up goals of care is really tough. I get frustrated sometimes as a hospice director that I don't see more oncology notes in the hospital chart because they've abdicated that, and I see that among some of my partners too, to the hospitalists. This weekend I had a hospitalist who tried to bring up a goals of care conversation, and the patient was very upset about it. You said, ask permission. I think that it's really critical when you have these discussions that you ask the patient's permission whether to have them, because some patients are ready and some patients aren't.
And that's what I've seen as well. There are patients who say, I just like to live one day at a time and stay hopeful. And I imagine with financial conversations, it'll be the same. Some people will say, that's not something I want to talk about right now. I just want to focus on getting the best treatment and getting stronger. And for others, if they have small children or other considerations, they probably would want to know.
Okay.
Yeah, I just want to echo and thank you for the comments. I think it's really not fair to the patient or to a person who's taking care of a patient but hasn't had a prior or will likely have a post relationship. It could be just during the admission, but it isn't somebody who has long-term care. And it just reminds me to say that in our world today, there's so many changes that have gotten kind of in between the idea of a patient having a provider or provider team that has long-term follow-up. We have lots of reasons why we have the electronic medical record, which in my view has in many ways gotten in between the patient and the caregiver. There's often much more concern about the computer than there is about the patient or interaction. But I think the real high point I wanted to highlight is the appropriate discussion, including about real-world implications, should come from a provider or foundation, et cetera, but there's some kind of relationship with the patient, not some, sort of in an emergency when they're very sick, and et cetera. It really should be in a very thoughtful way.
There were a number of points raised. I agree completely with you that no one should be bankrupted by a medical condition or by their cancer care. I would suggest that the solution is in fixing the problem that causes medical bankruptcies, which is finding solutions to the high costs of oncology and I would suggest also cancer drugs, which I personally think could be reduced in cost. And I do think I'd just like to point out that I think there's a difference between talking about goals of care, as Dr. Shanahan raised, which I think is really essential to the physician-patient relationship and a responsibility of doctors to know what their patients want. Whereas I think the financial stuff may be necessary these days, but again, in an ideal world, I don't think any of these decisions should be based on costs. I think they should be based perhaps on futility and if the drug is likely to help. But I don't think that someone should choose a cancer treatment based on the cost of that. It's unfortunate, a function of our lack of a system, and that's happening too often.
Wonderful discussion, and I think really nice segue. What I'd like to challenge the panel to is come back to the question of how much can we afford? Not maybe so much how much is worth it, because every life is invaluable, right? There is no price tag. But as a society, we're learning, even the US now, we're running out of money to pay for healthcare. It's threatening the US government budget. It's threatening nearly most middle-class family and lower-class family budgets, as well as industry that is spending now a lot of their payments is healthcare spending, and it's threatening their viability as well. What we haven't really discussed is this concern of rationing. Putting a value, I agree, is a problem as it's rationing care. It's rationing potentially promising drugs. But currently, there's more rationing occurring in the US, and it's at the physician level. It's physicians that experience patients choosing not to undergo care because of the cost. And that's not happening in any other Western society. So we're failing as a physician community, as the professional community, to providing the necessary care to our patients because of cost. And we don't have the excuse of a lower income country where we're not wealthy enough to afford this care. It's the out-of-control healthcare costs that are putting us in this dilemma. So coming back to these out-of-control healthcare costs that most health economists agree is what's different between the US and other Western nations, how are we going to control it? Because that ultimately will have to happen. Otis Borley reminded us in 20 years, healthcare spending will be outpacing family incomes. How will we fix it, and who should fix it? Is it the FDA? Is it CMS? Is it professional societies?
Thoughts?
Yeah, so I would recommend, if you all get a chance to read William Baumel's book, Cost Disease, in which he says that perhaps as a percentage of GDP, the fact that healthcare is rising isn't something to get terribly alarmed about. He also says that healthcare is special because there are some industries in which the cost just simply is not going to reduce. I think healthcare, doctors being one of them, teachers, orchestra, conductors, anything that has a little bit of a semblance of art. So then the question isn't so much the cost, it's the redistribution. It's how you protect the most vulnerable, those that are at the lowest level, and whether you can have a means-tested system of redistribution that is better than the one that we have right now, which redistributes, but perhaps doesn't redistribute quite as precisely as we might want to. So I would say that the focus should be on how we even out the regressive taxation to make it less regressive, and even the insurance is a form of taxation, as SCOTUS concluded, or at least its mandate or penalty was a form of taxation, and how we can even that. The second thing is that with the focus on costs, I think if we focused on effectiveness, we could deal with a lot of the costs without actually explicitly focusing on the costs. And focusing on effectiveness, in a sense, rations the use by making it more scientific. And so effectiveness is something that physicians can have a greater say in, like something as simple as radiology. Imaging effectiveness can come from having discussions with radiologists saying, well, will this test really manage information that's going to change my management, particularly with PET scans. And maybe we can reduce the frequency of PET scans. There's a lot that can be done. There's a lot of fat in the system that can be trimmed before we actually really need to talk about costs.
But actually, so there was a great Wall Street Journal article, summarizing the data, and it's not physician services that are driving the cost. They have plateaued. It's drug pricing and hospital costs that are driving these, and they're going up exponentially. And I think, as a medical society, yes, we can trim further, but it's not even the main driver of the cost. It's the pricing. And this is coming from, some of the Harvard health economy studies and several of the lead US economy studies. So it is the pricing that's out of control compared to the Western world, rest of the Western world.
Carla?
I am so glad you asked that question. And this came up yesterday when Shadi said that everybody has to have a little skin in the game. So at Family Reach, we started this Center for Research around financial toxicity to show how these financial barriers and how cancer is bankrupting family and how it affects everybody, how it affects the state, the government. My families are now on food stamps. What is that costing each state? My families are ending up in homeless shelters. What is that costing the state? I think once we segment out these different industries and show this, you think this isn't affecting you, it is, and here's why. 38% of cancer patients are cutting their drugs in half or putting off filling prescriptions. That is affecting pharma. Again, what is it costing the state? Mortgages, it's the #1 cause of bankruptcy and foreclosures. What is that costing the banks? So right now, Family Reach is piloting a loan modification program. So we're building this ecosystem outside of the healthcare industry because these cancer bankruptcies are affecting these other industries. So right now we have a pilot going with Wells Fargo that if you have a member with inactive cancer treatment, a family member in active cancer treatment, and you have a Wells Fargo loan, you don't have to pay your mortgage for a year, and it extends the length of the mortgage. So we're looking at this from many different angles to see if we can get how many stakeholders can we get involved and then get our Center for Research to measure the impact that these financial barriers are having on each one of these industries. Then maybe they'll look at it differently.
Carla, you've quoted some really important numbers. I'd like to add one more, which I found the most powerful one, that in about 2 years, 51% or nearly half, a little bit more than half of patients with chronic illness exhaust their life savings. That is huge. This is a societal threat to the US stability of families. If their financial security is a threat, if you get a chronic illness that goes beyond cancer, this is huge. So I'd love to come back to the key question, maybe some of the physicians in the room, who should fix, and I agree, effectiveness, which is a similar discussion as value, should drive our decisions, but who should drive the pricing so that we can provide affordable health care to all?
Yeah, part of the problem we have is that we allowed Captain John Smith to determine who gets paid for health care. If you don't work, you don't eat. And at the same time, we have decided as a society over time that we all have a right to all of the health care that we want. And those two things are juxtaposed. We, as I said, I think when I started, I think as physicians, we need to take responsibility for utilization. So yes, I agree that those things are way too expensive, but they are costing our society much more than they need to because we order things that we shouldn't order or that our patients aren't going to benefit from. And I think we have to own that and fix that. But there needs to be a greater discussion, and that's a societal discussion. We're beginning to talk about having a discussion about green in the United States. We need to have a discussion about what healthcare is. We have a lot of people talking about healthcare payment reform. Nobody's really talking about healthcare reform, and that's what we need to do.
Yeah. We have 3 more questions, and then we'll have to wrap up.
Hi, Hamed Mirzai. I am affiliated with Amgen. The question and comments are my own. I do not represent pharma, yada, yada, yada. I'm going to actually pivot this a little bit because I rephrased my question 3 times as I was getting closer to the mic. Thinking of it as a physics problem. We can have a Newtonian approach to it that makes sense, everybody understands, and fixes the problem in a more immediate sense. But then there's a quantum physics approach to it that is super complicated, and anybody that claims that understands quantum physics obviously doesn't understand quantum physics, but that's the one that actually solves the problem for the long term. And I feel like with this discussion, especially, I'm glad this came after the debate yesterday, if we're looking at the cost total all as a total phenomenon, that's a societal issue. But then, of course, that does not take into consideration each and individual patient. But then as each and individual patient, it's a whole different argument, because how do you put a value on an individual that you know life expectancy is 6 months? Do you give them 6 months, or you give them 3 months if you had to choose? Or should you get to choose? And this is where I guess I'm very glad you keep pushing back on who makes the choice. How much do physicians should be responsible for saying, no, this is my choice, you should get the treatment, or I'm going to give you all the options for the treatment? And how much of it should be driven by somebody up there that's collecting all the money saying, no, 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 these are the guidelines that we're going to obey by, and this is how the system should function so that the majority of the people in the society can have care. Thank you.
Comment?
I just want to, I hear you loud and clear. I think there's going to be value for the society and value for the patient. And I want to go back to the other question for a minute. Whoever makes that judgment, what really has come through loud and clear at this meeting, every single session, is the crying, urgent need for reform in all of the areas, right? But just to pick on a couple, if we, as we heard yesterday so beautifully in the debate, we need to reform how we administer care, whether it's single party payer or whether it's some other model or some hybrid, maybe soft, I learned yesterday. But whatever it's going to be called, we can't pay whatever the number is, 30 or 40% of the cost of healthcare for an administrative cost. Any other business would go out of business, and that's happening here. So that's one. And I do want to pick up on the cost of drugs, because when you're deciding the value for the society or the person, you have to think about what goes into the ultimate cost, right? And the cost of drugs, the cost of drugs is where it is. It's because the pharmaceuticals, and I work with all of them, are doing the best by their stockholders. That's their job. Can't blame them for that. Hey, that's the system. There's no negotiation by Medicare, Medicaid. Okay, but the point is, the distribution, the simple economic argument, if actually medicines went to a more broad population, not only in this country but in the world, in which there was actually evidence that they could benefit, the business argument would be they would succeed much greater. And I think it is really, it bothers me beyond what I can tell you when I know drugs that came into existence in the 1990s are still having 2 and 3 times a year increments in their cost. On what basis, I might wonder. In fact, I could argue the other way. The drugs end up getting used much more broadly than was ever anticipated. So in fact, the revenue, it should come down. But the system is such that it's allowed, and so it happens. And so I think if we could reform how we administer healthcare, as was talked about yesterday, and a little bit here, as you were bringing up in terms of the cost of drugs, that would go a long way. And the hospital costs, which are going way up too, are not unrelated to those two problems, because the hospitals are reacting to all the regulations that are happening and the cost of medicines that are happening, and so it's all tied together. So I just think this has been such a healthy discussion on all aspects, and this sort of builds on what we did yesterday.
Yeah. Julie?
I just want to answer a question very quickly. About who? A few years ago, I was at an overdiagnosis conference, and I said, I can solve the problem of overdiagnosis and incidental findings in one stroke. And everyone was curious, what? I said, I'm just not going to report them. I won't report an adrenal nodule when I see one. I won't report a lung nodule when I see one. Just give me legal immunity and it'll be solved. And there was uproar in the audience. How dare you? It's the patient's decision, not yours. So in terms of who, I think Americans take a very dim view of medical paternalism. And in fact, actually, even the Brits do, increasingly these days. They don't just express it to a doctor, they express it to the Daily Mail. So we have to be cognizant of cultural values and values which clash. And we seem to want two things: control of the costs, but preservation of individual decision making. And the two are fundamentally oppositional, and one needs to give if one has to prevail.
Julie.
My comment to that would just be that I think the professionals should make the professional decisions, and just because I know how to read papers, does not make me an expert.
Okay. Julie.
So I think it's a given that industry is going to get the broadest possible label and price at what they think the market will bear. I don't think I can have a major impact as a medical oncologist and a clinical trialist on the price of the drug. But I think we can, across populations, lower the cost of cancer care by better defining which patients benefit from a drug, from de-escalating therapy, and that will result in us giving a lot less of drugs, even though we might, for a given patient, still be spending a lot. So do I think everybody needs a CDK4/6 inhibitor who has ER-positive metastatic breast cancer? No, I've got patients for 20 years in my clinic who have done fine on an AI alone. But I don't know who not to give the CDK4/6 inhibitor to. Is there a little medical legal fear of not giving it or something? I don't think for me, but I think there is. Do I think everybody needs dual trastuzumab, pertuzumab with HER2-positive metastatic breast cancer? No. No, I had patients who did fine without the pertuzumab years ago. And once that label is given and it's broad, then there's no incentive for industry to do. But I do think that the government and foundations can help us support research to figure out who doesn't need it. And I think, especially with my global oncology hat on, as we're looking to move some of these expensive targeted therapies into low and middle income countries, that's going to be where we solve some of the issues of duration of treatment, for example, of trastuzumab in the adjuvant setting, subpopulations that don't benefit, because they're not established already that this is their standard of care. So their comparator is none of this therapy versus some of it. And so, for example, we have a Uganda protocol where we just want to give pre-op trastuzumab. And in locally advanced HER2-positive patients. It's tough enough to figure out how to test for the HER2 even. But we're getting a lot of pressure that, nope, that's not standard of care. You need to give a whole year, even though our endpoint for the trial is surgery after about 12 weeks of therapy. So I'm just saying, I don't feel I can make as much of a dent on the cost of drugs. Other people can, but I can actually help lead research and advocate for giving less of a lot of drugs and figuring out how to do that.
And perhaps the global community can teach us as much as we teach them as we go forward with this. Yes.
Yeah, Dave Abalafi, I think the panel's terrific, and you've all made such incredible points. As a clinician, I'm kind of wildly going after, there were so many big themes here. The best systems are the ones that have great social workers, have financial navigators. Many of our cancer clinics don't have that. And the cancer docs are not going to be able to do it. They're already overwhelmed. The issues with clicking, the Medscape article on 1,000 deaths by clicking or whatever it was, 1,000 cuts by clicking, really cuts into us. Some oncologists have no facility in talking about really difficult issues, ironically. So having a great palliative care program, some of the programs don't have palliative care. What goes in those situations? One thing that I think would make things a little bit easier, and I had this little exercise in our own group, denosumab versus Zometa. There had just been a paper, and it was, it came out very nicely. And I went around and I go, well, how much is this new drug? And I had no idea. And then I asked our pharmacist, so it took them a couple clicks. They were able to pull it out. It's about 8 times more expensive. And then I went to my group and I said, how many of you are using denosumab? Well, one guy said, it's sub-Q and my patients like sub-Q. I give it for everyone, And I said, Tom, do you know? And he's a palliative care doc, in his other hat. So I said, did you know the difference in costs? And it changed. How nice it would be if when I pull up Citrix and I order Augmentin or amoxicillin, Cipro or Levaquin, Taxol or whatever, there's a little pop-up that tells me in our system, what is that? Even our pharmacists didn't really know how much it was going to cost because there was an interplay between the pharmacist and the purchaser. So we had really no way of knowing. But if there was that, it could really inform a lot. And, you know, as an oncologist, it'd be like impossible not to know that adriamycin has a cardiotoxicity, that certain drugs like thalidomide cause peripheral neuropathy. Financial toxicity is equally, and maybe in some cases, even bigger concern for some of our patients, but I have no way of knowing that component of it.
And we need to solve that, no question about it. I'll give you the last word.
Thank you. So I just wanted to piggyback on what you said about the global thing for patients in low-middle income countries. So I practice in University of Chicago and in Nigeria. And it is very difficult for you to work in a place where there is chance of survival. And then you move to a place where the chance of survival is almost zero, just because of geographical location. I think that is very unjust. So the drugs that are made available to places like Africa are paclitaxel, old chemotherapies, and that's it. What about the targeted therapies? What about the new drugs? And right now we are working on developing an African consortium, increasing the market power, and cutting the middlemen that supply a lot of things, you know, because the middlemen, the customs and all that, and that's a problem. When you I've tried to approach those pharmaceutical industries themselves, and they always move me back to the middlemen. How do we do that? How do we cut how do we cut all these people and negotiate directly with the middlemen? How do we negotiate the way the British, the Canadians have negotiated? We know that Americans don't negotiate, that's cool, but we need to be able to negotiate. So how do we come to the table to negotiate all those prices? And then the other thing is training. We see the IDEA Award, whereby they bring physicians from low-middle income countries to do a year of observership and all that. I think that's so wrong, because all they do is observe. After a year of observing, after a week of observing, that's it. The rest of the thing, you're not doing anything. So because of EPIC, HIPAA, and all that, you can't touch the patient, you can't do anything. And I think we should actually ask ourselves that if people cannot come from low-middle income countries to touch patients here, I'm not sure what we are doing is actually right, and I'm not sure that we are truly improving cancer care in this part of the world. So my question to you, sir, is that for Britain, how have you been able to get the pharmaceutical industry to the table and cut the middlemen so that we can probably use that in our own environment? Thank you.
So they have a very robust culture of actually accepting that first, healthcare is a right, second, that it has to be rationed, and third, that it has to be rationed by an independent body, and the body truly is independent. The National Institute of Clinical Excellence, it comprises economists, physicians, and also people who are neither, to come to the table together. Now, pharma, when it deals with them, it also goes back road in trying to get patient support groups to sometimes try and overturn decisions, or make a big song and dance about certain decisions. So it's not as pure and clear cut. But the point is that if you're going to have something similar in low middle income countries, then it has to be a body that is completely independent of the government and not prone to any pressures from the government or any corruption from the government. Otherwise, that would nullify the effect of it. So independent is the key point here.
Well, we're going to have to end there. I'd like you to thank our panelists for their excellent discussion.